There's a small orange bottle that sits on more kitchen counters in this country than most people realize. It might say warfarin. It might say apixaban, rivaroxaban, dabigatran. The names are different. The purpose is the same. And for a significant number of people over 60 who take one of these medications every single day, sometimes twice a day, the actual understanding of what that pill is doing inside their body, what it can cause, what it prevents, what it interacts with, and when it can quietly become dangerous is somewhere between incomplete and nearly absent. That's not an accusation. It's an observation I've made over a long time across a lot of clinical encounters. People take these medications because a doctor told them to. They refill them. They try not to forget the dose, and they move on with their days. What most of them were never given, or were given once, briefly, in a way that didn't stick, is the real picture, not the pamphlet, the actual picture. What's happening in their blood? What can go wrong in both directions? What they're watching for without realizing they should be watching. This video is for those people. And if you're not taking one of these medications yourself, there's a very reasonable chance someone you live with or care about is. Let me start where the story actually starts for most people, because it usually doesn't start with the anticoagulant. It starts earlier with something that happened, or almost happened, or was discovered incidentally, that led a physician to conclude that the blood needed to be made less prone to clotting, and the most common reason that conversation happens after 60 is something called atrial fibrillation, which is where I want to begin, because there's a version of this condition that is almost perfectly invisible, and I don't think enough people over 60 know that it exists. The heart has a rhythm, a reliable, organized electrical sequence that coordinates the chambers and produces a consistent, efficient pump cycle. Atrial fibrillation is what happens when that organization breaks down in the upper chambers, the atria, which begin firing chaotically instead of in a coordinated beat. The result is an irregular, often rapid rhythm that most people associate with palpitations, with the sensation of a fluttering or pounding in the chest, with shortness of breath, with fatigue that doesn't make sense. Those are the symptoms people recognize. Those are the symptoms that bring people in. But there's another form, and this is the one I want you to sit with for a moment, called silent atrial fibrillation. Paroxysmal, intermittent, or persistent AF that produces no sensation whatsoever in the person experiencing it. No flutter, no racing heart, no breathlessness. The atria are fibrillating in a pattern that the individual's nervous system either doesn't register clearly or has adapted to in a way that makes it background noise. The person feels nothing unusual, might describe their energy as slightly off, their exercise tolerance as mildly diminished, but nothing that demands investigation, nothing that points to the heart. And in those upper chambers where the rhythm is chaotic and the blood is moving sluggishly, instead of being pumped out efficiently, small clots are forming. Not always, not continuously, but intermittently in the stagnant blood that accumulates in those fibrillating chambers, and those clots, when they dislodge, go into circulation. They travel through the arteries, and a meaningful proportion of them end up in the brain. That's the stroke that comes out of nowhere. The stroke that arrives in someone who seemed fine, who had no risk factors anyone knew about, who had been living with silent atrial fibrillation for months or years, unknown, unmonitored, untreated, until the day a clot lodged in a cerebral artery and the brain lost blood supply to a region it couldn't recover from. That stroke, that specific stroke driven by AF-related clot, is not minor. It tends to be large because the emboli that come from the heart are larger than the clots that form in the arteries themselves, and large strokes leave large deficits. I mention all of this not to generate fear, but because I think the context matters for understanding why anticoagulants exist in this population. They exist because this specific mechanism, AF-related clot formation and embolization, is real, it's common, it's often silent in its early stages, and it's addressable. Anticoagulation dramatically reduces the risk of stroke in people with atrial fibrillation. That is not a minor claim. It is one of the better supported findings in cardiovascular medicine. For the right patient, the right anticoagulant is genuinely stroke-preventing medicine. That matters. It matters a great deal. But here is where the conversation usually ends in the clinic, and where I think it should begin. Being told that a medication reduces stroke risk is not the same as understanding that medication. And with anticoagulants specifically, this class of medications, the gap between receiving the prescription and genuinely understanding what you're now managing is consequential in a way that it isn't for most other drug classes. These are not gentle medications with soft safety margins. They work by interfering with the body's clotting mechanism, deliberately impairing a function that exists to stop bleeding when blood vessels are damaged. That is, by definition, a mechanism with consequences on both sides. Too little effect and clots form, too much effect, and bleeding becomes difficult to control. The therapeutic window, the zone between insufficient and dangerous, is real, and it has to be actively maintained. And most patients sitting across from a busy physician, receiving a discharge prescription, filling it at a pharmacy with a pharmacist who hands them a stapled-together printout, do not receive a working understanding of that window. What I want to do is give you that understanding, not the pharmacology textbook version, the version that actually translates into daily life after 60. Warfarin is the oldest of the commonly used anticoagulants, and in some ways the most demanding. It works by interfering with vitamin K-dependent clotting factors, several proteins in the coagulation cascade that require vitamin K to become functional. Blocking that process reduces the blood's ability to form clots. It sounds clean. The clinical reality is considerably less clean because warfarin's effect is highly sensitive to a large number of variables: diet, other medications, illness, changes in body weight, gut health, alcohol intake. The dose that was appropriate 3 months ago may no longer be appropriate today for reasons that have nothing to do with whether the patient followed instructions. This is why warfarin patients require regular INR monitoring, a blood test that measures the clotting time and determines whether the anticoagulant effect is within the therapeutic range. Too low, risk of clot. Too high, risk of uncontrolled bleeding. The INR monitoring is not optional. It is the mechanism by which warfarin is managed safely. And yet I have seen patients who missed monitoring appointments routinely, sometimes because life got complicated, sometimes because transportation was an issue, sometimes because nobody had clearly communicated what the consequence of missing a test actually was. The INR is not bureaucratic lab work. It is the only real-time signal that tells you whether warfarin is currently doing what it's supposed to do or whether it has drifted into a range that is actively dangerous. If you or someone you care for takes warfarin, the monitoring schedule is not optional and is not something that can be managed by feeling fine. Warfarin toxicity does not announce itself reliably before it causes a serious bleed. That is the nature of what it is. The newer anticoagulants, direct oral anticoagulants, what clinicians call DOACs, work differently. Apixaban, rivaroxaban, dabigatran, edoxaban. They directly inhibit specific factors in the coagulation cascade, either thrombin or factor Xa, without the dietary interactions and the constant monitoring demands of warfarin. That's a genuine advantage. These medications have largely replaced warfarin for many patients because their effect is more predictable, their drug interactions are fewer, and the management is simpler. A fixed dose twice a day or once a day without the INR testing. The word I want to flag there is simpler. Simpler is not the same as safe without understanding. And what I find in practice is that the simplification of the management has sometimes led to a corresponding simplification of the patient's understanding of what they're taking. Because you don't go in for monthly blood tests because there's no number being tracked, it can start to feel like any other medication. Take it every day, refill it. That's the management. And that understanding is incomplete in ways that matter. DOACs still carry bleeding risk, significant bleeding risk. The absence of INR monitoring doesn't mean the medication isn't doing something powerful. It means the effect is more predictable, not that it's stopped happening. A patient on apixaban who falls and strikes their head is at risk for intracranial bleeding. A patient on rivaroxaban who develops a gastrointestinal bleed may bleed more substantially and for longer before the body can arrest it. The coagulation system is impaired. That impairment is the point of the medication, but it exists in situations beyond the specific stroke prevention context for which the medication was prescribed. I want to stay on the falls question for a moment, because it's the one that generates the most complicated clinical conversations I have with patients over 60. The logic of the concern is real. Anticoagulants impair the body's ability to stop bleeding, and falls in older adults carry a meaningful risk of serious injury, including head injury. A fall that would produce a minor bruise and a headache in someone without anticoagulation can produce a serious intracranial bleed in someone whose clotting mechanism is intentionally impaired. That risk is not hypothetical. It is documented and real. And yet, and this is the part that gets lost, the alternative is not without risk either. Discontinuing anticoagulation in a patient with atrial fibrillation restores full clotting function, which means it also restores full stroke risk. The clinical question is always, which risk is larger for this specific person? And that answer depends on the individual's stroke risk score, their fall risk, their living situation, their cognitive function, their ability to maintain awareness of bleeding signs, and a dozen other variables that cannot be reduced to a generic recommendation. What I see go wrong is when the patient, or more often a family member with good intentions, makes that decision unilaterally. They read something about falls and blood thinners. They become frightened. They quietly stop the medication, or reduce the dose, or give it inconsistently, without telling the prescribing physician. And they don't tell the physician because they're afraid of being told they're wrong, or because they've convinced themselves that the modified approach is a reasonable compromise, or because the next appointment isn't for 3 months and it doesn't feel urgent. Meanwhile, the stroke risk that prompted the prescription in the first place is now fully active again. This is not a hypothetical pattern. I have seen it more than once. The conversation that follows when something goes wrong is one of the worst conversations there is. If you have concerns about fall risk on anticoagulation, and those concerns are legitimate, the answer is to have that conversation with the physician. Not as a negotiation, but as a genuine clinical discussion about the risk-benefit balance for your specific situation. There are tools that assess stroke risk and bleeding risk in parallel. There are strategies for fall prevention that address the other side of the equation. There are anticoagulant reversal agents available in emergency settings that didn't exist 10 years ago. The clinical landscape for managing this class of medications is better than it has ever been, but it requires engagement. It requires communication. Quiet self-management around these drugs is where outcomes go wrong. Before I continue, if you're watching this because someone you care about is on one of these medications, or because you've been prescribed one and never felt like you fully understood it, please subscribe and like this video. I want to cover what comes next because the interaction questions are the ones that generate the most confusion in practice, and I want to make sure you have them clearly. Let me talk about interactions because this is where the practical daily management of anticoagulants in real life gets complicated in ways that a prescription pamphlet doesn't fully prepare you for. Warfarin first, because the interaction profile is the most extensive. Vitamin K is the most widely known. Warfarin works by blocking vitamin K-dependent clotting factors. Dietary vitamin K, present in green leafy vegetables, particularly kale, spinach, broccoli, Brussels sprouts, can counteract warfarin's effect by providing more substrate for the clotting process. This doesn't mean that someone on warfarin should avoid these vegetables. That's not the guidance. The guidance is consistency. The problem is not eating spinach. The problem is eating very little spinach for 3 weeks and then having a week of daily salads. That fluctuation in dietary vitamin K creates corresponding fluctuation in the INR, which makes the anticoagulant effect unstable. Consistency matters more than avoidance. If you eat leafy greens regularly, the dose of warfarin is adjusted to account for that. What disrupts the balance is inconsistency. The person who eats well for a period, then doesn't, then does again because each shift in vitamin K intake shifts the INR. Alcohol is another dimension that gets underestimated. Moderate alcohol use can affect warfarin metabolism in the liver. Heavy or binge drinking is more significantly disruptive. And with DOACs, alcohol doesn't affect the medication through the same mechanism, but creates independent bleeding risk. The gastrointestinal lining, already somewhat vulnerable to irritation in older adults, is more susceptible to bleeding when both alcohol and anticoagulation are present. That combination, a glass of wine every night with full anticoagulation in place, is not automatically dangerous, but it's a combination worth discussing explicitly with a physician rather than assuming is fine because neither element seems extreme. Medications are the largest interaction category, and this is where over-the-counter drugs cause the most invisible trouble. NSAIDs, non-steroidal anti-inflammatory drugs, ibuprofen, naproxen, aspirin in anti-inflammatory doses, affect platelet function independently of anticoagulants. They work through a different mechanism, but the net effect is additive. Both the anticoagulant and the NSAID are impairing the body's ability to form a stable clot, just through different pathways. The combination significantly increases bleeding risk, particularly gastrointestinal bleeding, and NSAIDs are available without a prescription. They're taken casually for arthritis, for back pain, for headaches. Someone who's been managing their joint pain with ibuprofen for years may continue doing so after starting an anticoagulant without recognizing that the combination has changed the risk calculus entirely. Certain antibiotics interact with warfarin, sometimes dramatically. Antifungal medications, some herbal supplements, ginkgo, garlic, fish oil in high doses, St. John's wort, all have interaction potential with anticoagulants at varying levels of clinical significance. The challenge is that supplement doesn't mean inert. Biologically active compounds are biologically active regardless of whether they're sold in a pharmacy or a health food store. And the patient who carefully lists their prescription medications for every provider but doesn't mention their supplements because supplements feel categorically different, is presenting an incomplete picture that can produce unexpected outcomes. The principle I try to make clear is this: If you are taking an anticoagulant, anything that enters your body that has biological activity needs to be on the table in conversation with whoever manages your anticoagulation. That includes over-the-counter medications, herbal supplements, vitamins in therapeutic doses, and significant dietary changes. This isn't excessive caution. It's the mechanics of a class of medications that interact broadly with the body's chemistry. I want to describe some specific signs that deserve immediate attention in someone on anticoagulants, because these are the early warning signals that the medication's effect may have moved out of the safe range on the bleeding side. I say this not to create anxiety, but because the window between manageable and serious can be shorter with these medications than with many others, and early recognition matters. Unusual or unexplained bruising, bruising that appears without a known cause, or bruising that seems disproportionately large relative to minor contact, is a visible sign that clotting is impaired beyond the intended therapeutic level. One bruise is not a crisis. A pattern of unexplained bruises appearing regularly is a signal. Blood in the urine, a pink, red, or brownish tinge that is new and isn't explained by dehydration or food, warrants same-day contact with a physician. Blood in the stool, visible red blood or black tarry, distinctly foul-smelling stool that represents digested blood from higher in the gastrointestinal tract, is an emergency. Prolonged bleeding from a cut that doesn't slow normally within a reasonable time, coughing up blood, or noticing blood in vomit. Severe headache that is sudden and unusual in character, particularly one accompanied by vision changes, confusion, or weakness. This is the presentation that should prompt emergency evaluation, because intracranial bleeding can begin with a headache before it progresses to neurological deficits. The last one I want to name is less dramatic but persistently missed: spontaneous nosebleeds that are difficult to stop, particularly in someone who rarely had nosebleeds before. In a person on anticoagulation, a nosebleed that runs for 15 or 20 minutes without slowing despite direct pressure is not a minor inconvenience. It is the visible surface evidence of an impaired clotting mechanism, and it warrants contact with a physician to review the current medication levels. None of these signs means the medication is wrong for the patient. They mean the current level of anticoagulation may need adjustment, or that something has changed, a new medication, a dietary shift, an illness that has disrupted the balance. The response to these signs is contact with a physician, not stopping the medication on your own, not doubling down by skipping a dose in the other direction, contacting whoever manages the anticoagulation and reporting what you've observed. I want to say something now about a pattern I find genuinely troubling, and I say it as directly as I know how to say it. There is a subset of patients over 60 who take anticoagulants, sometimes for years, without a clear ongoing understanding of why they're still taking them. They started on the medication at some point, the refills kept coming, and the question of whether the indication is still present, whether the risk-benefit balance has shifted, whether the type of anticoagulant is still the most appropriate option, those questions haven't been revisited. The prescription exists in a kind of clinical inertia. Nobody has done anything wrong exactly, but the ongoing conversation that should be happening around a medication, this significant, isn't happening consistently. The person who started warfarin after an AF diagnosis 5 years ago may now be a different clinical picture, different weight, different kidney function, different fall history, different additional medications than the person who was prescribed it. The DOAC that was started when the medication was newer and the evidence base was emerging may now have updated dosing guidance or newer alternatives relevant to their profile. The periodic reassessment of anticoagulation therapy is a legitimate clinical activity, not a challenge to the prescribing physician. If you've been on one of these medications for more than a year or two without a substantive conversation about the current indication, current alternatives, and current monitoring plan, that conversation is worth initiating. That's not me suggesting you question your treatment. It's me suggesting that you be an active participant in it. There is a significant difference. I'd like to hear from you directly about this, specifically in the comments. Are you on anticoagulation, or is someone close to you? And if so, do you feel like you genuinely understand what the medication is doing, what to watch for, and what the current plan looks like? I ask because the range of experiences people have with this is enormous. Some people are very well informed and feel well supported, and others are taking these medications essentially on faith, with very limited understanding of what they're managing. Both experiences are worth naming, and both tell me something real about what people are actually going through. Let me spend a moment on one more dimension that gets overlooked: what happens when a procedure or surgery is needed. This is a situation that comes up for most people on anticoagulants at some point, and the management of it is something many patients have never thought through in advance. Anticoagulants need to be managed around invasive procedures: an operation, a dental extraction, a colonoscopy, an injection, any procedure that involves significant tissue disruption. All of these carry bleeding risk that is altered by anticoagulation. The management varies. Some procedures can be performed with the anticoagulant maintained or briefly held. Others require more careful planning with bridging strategies or timed discontinuation. The critical point is that this management needs to happen in advance and in coordination between the procedural provider and the prescribing physician. The scenario that creates problems is when a patient undergoes a procedure, including dental procedures, which are often not disclosed to the anticoagulant prescriber, without either provider knowing about the other context, or when a patient is told to stop the anticoagulant before a procedure, does so, and then no one follows up on when and how to restart it afterward, leaving the patient in an anticoagulant gap of indeterminate length. Both directions of error occur. Procedures done without appropriate anticoagulation management, leading to intraoperative or postoperative bleeding, and anticoagulants being held without a clear restart plan, leaving the patient without protection during the recovery period when clot risk is actually elevated by the physiological stress of surgery. Both are manageable when there's coordination. Both are problematic when coordination doesn't happen. If a procedure is coming up, the conversation to initiate proactively is: who is managing the anticoagulation hold and restart? What is the specific plan? And who needs to communicate with whom to ensure it happens as intended? That conversation is worth having before the day of the procedure. I want to come back to something I mentioned earlier, because I think it's where the most important meaning in all of this lives. The stroke that anticoagulants are preventing, particularly the AF-related stroke, is among the most consequential health events that can happen to someone over 60. It is not like most medical events in the sense that recovery brings you back to a prior state. Large strokes, the kind most commonly associated with atrial fibrillation and cardiac embolism, leave permanent deficits. They change life circumstances, independence, cognitive function, sometimes personality, sometimes the ability to speak or move. They are not recovered from in the way that a fracture heals or a cardiac event is treated. They represent a before and an after, and in many cases, the person who was before is not fully accessible afterward. Anticoagulants in the right patient meaningfully reduce the probability of that event occurring. That is what they're doing every day. That is the weight of the medication that sits in the orange bottle on the kitchen counter. Understanding that, really understanding it, not just knowing it as a fact, changes the way you relate to the medication. The dose you don't want to take because you feel fine and it seems unnecessary. The monitoring appointment you keep rescheduling because nothing seems urgent. The NSA ID you take for your knee without thinking about it because it's just ibuprofen. Each of these seems small. In the context of what the medication is protecting against, they're not small. I'm not asking for anxiety or hypervigilance. I'm asking for proportional understanding. You are taking a medication that requires attention, not obsessive attention, not medically dominated daily attention, but genuine, informed, ongoing attention, the kind that notices when something unusual is happening and responds to it, the kind that communicates changes to providers rather than managing them silently, the kind that knows why the medication is there, what the signs of too much or too little are, and what the stakes of the balance are. That understanding is not complicated. It's just not being given out routinely enough. And before I leave you with that, I want to say something about the people who are watching this and haven't been told they need anticoagulation, and who are wondering now whether they should be asking about it. The appropriate question is not, should I be on a blood thinner? That's a clinical determination that requires actual evaluation, an EKG, an assessment of rhythm, a calculation of stroke risk based on multiple factors. It's not a decision based on a YouTube video. But the appropriate question to bring to a physician after 50 is, have I been evaluated for atrial fibrillation? Has my rhythm been assessed recently? What is my current stroke risk profile? Because silent AF is real, because the risk increases with age, because the evaluation is simple, and because the cost of asking is nothing, while the cost of not asking is occasionally very high. That's the question. A simple, direct question in a routine clinical context. It doesn't require urgency or alarm. It requires asking. If you found this useful, if this is the kind of depth and specificity you want from a channel focused on what actually matters in the body after 60, subscribe and make sure notifications are on. Because what I'm trying to do here is give people the fuller picture, not the pharmaceutical pamphlet, not the headline, the actual functional understanding that changes how you manage your health day to day. That's the work, and there's more of it ahead. The orange bottle on the counter is not just a pill to take and forget. It is a daily intervention in one of the most consequential physiological processes in the body. It deserves to be understood, and you deserve to understand it.